I think the first three talks this morning are on a subject that we deal with very commonly at the Mitchell Cancer Institute. These patients who have primary and also secondary liver cancers are very challenging to deal with, and so I'm very excited that we've got three talks addressing this particular topic. My talk, I think, is really a set-up talk for Dr. Rahim and Dr. Cha about first interventional radiology and the role of liver-directed therapy, and then for the role of stereotactic body radiation. And really, I think the major take-home message is, just like many other cancers, management of primary and secondary liver cancer is a very, very complicated thing. And so as a result, involvement of many different disciplines throughout the care of these patients is extremely important. No disclosures. And the outline, as I mentioned, I'll talk a little bit about HCC, both in terms of its demographics nationally and also locally, how we go about making decisions, and also how surgeons view the management of HCC, and then conclude with a little bit of a summary about our liver, biliary, pancreas program here at the Mitchell Cancer Institute. So take-home messages for those people who haven't, who've had a little bit of coffee but hasn't quite kicked in yet. HCC is an evolving epidemic in the world of cancer. I'll give you a bit of data about that in just a moment. And as I mentioned before, there are multiple diverse treatment options, and as a result, it's very important that we integrate how we provide care for these patients. So at a national level, HCC is the 12th most common cancer. There are about 40,000 cases per year, and the incidence is rising. And as you can see here, it's in the top 10 cancers in terms of cancer mortality, both for men and women, and that rate is also increasing. Disappointingly, the median survival is about 6 months, and the 5-year survival is around 18%, which obviously are just terrible numbers. In Alabama, just across the border from here, you can see that both the incidence and the mortality are worse than national average, and that the incidence and mortality are really the worst for these common cancers listed. And in terms of patients who are at risk for primary liver cancer, this is a bit of a laundry list, but I think the take-home points are that it's primarily those patients with viral hepatitis, especially hepatitis C here in North America, and also the growing epidemic of obesity and the rise of steatosis and fatty liver. And as I mentioned before, the care of patients who develop hepatocellular carcinoma requires multiple disciplines, both at the level of initial diagnosis and particularly at the level of treatment. Diagnosis is often not straightforward, so hepatologists who follow patients with cirrhosis are crucial for screening and for initial recognition of the development of nodules within the liver, which may or may not be liver tumors versus just regenerative nodules, and then the role of diagnostic imaging for formal diagnosis of these lesions versus the need for biopsy is also something that requires multiple disciplines. And then, as we'll talk about in a little bit, all these people here are involved in initial decision making and then a subsequent follow-up and further decision making as we go along. And so the issues with regard to treatment are not just how initially to treat these patients, but also in sequencing treatments, combining treatments, and then coordinating multiple treatments across the various specialties. And so if we walk along the pathway about how to manage these patients, I think this is a very basic algorithm as laid out by the National Comprehensive Care Network, or NCCN. So those patients with metastatic disease versus not metastatic disease, if they do not have disease outside the liver, then we first consider whether they're potentially resectable or transplantable. And then if they're not, then consider them for local regional therapies, sorafenib, on clinical trials. And so just walking along this algorithm, if we consider first those patients who have metastatic disease, well, there's not a whole lot that works. And really, it comes down to 2 trials and 2 drugs that can be used in patients with metastatic primary liver cancer. First of these is a trial from the New England that was published in 2008, so almost 10 years ago. And so the SHARP trial randomized patients, 600 patients or so with advanced hepatocellular carcinoma to either sorafenib or placebo, and found that there was a 2.8-month increase in overall survival from almost 8 months to almost 11 months, and that the 1-year survival rate was improved from 33% to 44%, and there was a small increase in the time to radiologic progression. These are the Kaplan-Meier curves substantiating those numbers, and you can see that there's a fairly consistent separation of the 2 curves that appears to widen somewhat over time. But note the short timeline, this is a year. And so really the only other trial that has shown efficacy for chemotherapeutic agents in primary liver cancer is Regorafenib, and this is a trial that was just published earlier this year in The Lancet, and it's a trial for patients with advanced HCC, just like in the SHARP trial, who had progressed on sorafenib. So this is a second-line trial. Once again, very narrow inclusion criteria, so they have to have excellent performance status, good liver function, and had to be able to, and they excluded patients who had not tolerated sorafenib because of adverse effects. And they were randomized to either regorafenib or placebo. And once again, just like in the SHARP trial I showed before, there's a prolonged and widening survival gap between those who got regorafenib versus placebo, and the survival benefit was almost identical in that there was a 2.8-month increase in overall survival for patients who received the study drug. And this was also substantiated in the response rates where there was a small increase in the partial response rate. And so that's really it for metastatic HCC. You either have sorafenib for first line or regorafenib for second line, and these trials are separated by a gap of almost 10 years. And over those 10 years, there were multiple other randomized phase 3 trials examining both first line and second line drugs, and all those other trials had failed. So now if we turn our attention to the non-metastatic section of these patients, and then consider potentially resectable or transplantable patients, then decision making really depends on the characteristics of the tumor and the degree of underlying liver dysfunction, given that most of these patients have cirrhosis. And to break it down very simply, those patients who are cirrhotic, they either have adequate liver reserve, and that's defined by their Child-Pugh status and also the extent of the remaining liver, or what we call the future liver remnant after resection. That's either adequate or inadequate. If after you take out the tumor and the surrounding liver, there's not enough left to support native liver function, and in cirrhotics that number usually needs to be around 50%, then they're not a candidate for resection, and the only surgical option is liver transplantation. If they do have adequate liver resection, adequate liver reserve, then transplantation or resection are both options. And so for those patients with particularly hepatitis B who often will not have cirrhosis, then they're not a candidate for transplantation because they don't have cirrhosis. And so the options are either resection or if they have inadequate liver reserve, then local regional therapies. And so there's been no randomized trial comparing orthotopic liver transplantation to resection for patients who can undergo either. The best we have are some retrospective intention to treat analyses such as this one from the Barcelona group, in which they looked at a small group, so 75 versus 87, who were either resected or underwent orthotopic liver transplantation. And you can see here from this either comparing the group with who had underwent partial hepatectomy or just liver resection versus orthotopic liver transplantation, that the numbers are in the same kind of ballpark, though the 5-year survival for patients with orthotopic liver transplantation appears to be greater, so 70% versus around 50% for those patients who got partial hepatectomy. And for those patients who got resection and not transplantation, those patients who had worse liver function, so portal hypertension or hyperbilirubinemia, did worse than those patients who did not. And so how do we decide which patients get liver transplantation? Well, those, our decision making really is based upon the Milan criteria out of the Barcelona group, and this was published by Mazzaferro in the New England Journal now almost 20 years ago, versus the expanded UCSF criteria. And basically, the expanded UCSF criteria, which are the criteria we now use in Alabama, both here at the Mitchell Cancer Institute and also at UAB, that that having a single tumor greater than, or up to, 6.5 centimeters, or up to 3 tumors with none greater than 4.5 centimeters, or a cumulative tumor size of up to 8 centimeters. And you can see from these curves here that the 4-year survival is around 50 to 60%. And so what about the other potentially curative modality for HCC, which is ablation, and how do the results of ablation compare to patients who have surgical resection? So this is a randomized trial that was published in 2010, comparing patients who met the Milan criteria, who either got resection or radiofrequency ablation. And you can see that in this trial, the recurrence rate was greater for ablation than for resection. And this was borne out both in recurrence-free survival of about 30% versus 50%, and also in 5-year overall survival. You can see that there's a pretty broad separation of the survival curves. And so I'll talk very briefly about the role of adjuvant chemotherapy for patients who do get either resection or ablation. And this is a trial that was published a couple of years ago looking at the role of sorafenib as an adjuvant after resection or ablation. So this is a very large trial, over 1,000 patients, and they had to have shown that there was complete radiologic response after resection or ablation, and they either got sorafenib for 4 years or for up to 4 years versus placebo. And Dr. Cushman over here is thinking, well, 4 years of sorafenib, that's a very long time to treat a patient with sorafenib. And I guess, and so on the results, no patient managed to tolerate sorafenib for more than 3 years, and half continued the sorafenib after a year. So I think it gives you an idea about how poorly tolerated sorafenib is, both from a patient tolerance point of view and also because of a recurrence point of view. And you can see here from this Kaplan-Meier curve that they completely overlap. And so there was clearly no significant difference in recurrence-free survival whether patients got sorafenib or placebo. So really that's kind of my setup talk in terms of the overview of hepatocellular carcinoma from a surgeon's point of view, and from a overall multidisciplinary point of view. And I'll just talk very briefly about our system, I guess, for taking care of these patients here at the MCI. And a lot of this I've mentioned over the last 10, 20 minutes or so, in that these are, whether we're talking about pancreatic cancer or hepatocellular carcinoma or liver metastases from colorectal cancer, these are without a doubt very aggressive malignancies. And I mentioned that these can be a diagnostic challenge, and and difficulties in making the diagnosis can result in not only a delay in diagnosis, but obviously in treatment. And that, as you can see from this very helpful sign, the way forward is not always a straight line or any particular clear direction. And so multimodality treatment is the rule rather than the exception. And as you can see here, this is from the most recent version of the NCCN guidelines. That's really the first thing they say. So once you know that it's HCC, then as a group of physicians who have expertise in this area need to get together and discuss these patients. And the grouping here in terms of metastatic disease, resectable or transplantable disease, unresectable disease, or poor performance status are really the first points of decision in terms of how to manage these patients. And so how are we organized and what's our system for taking care of these patients? Well, this is something that we put together and initiated in the early part of last year. The Hepato-Pancreato-Biliary Program consists of a weekly consensus conference. We have a database and actually more than one coordinator now, and really encompasses a very wide variety of physicians who have an interest and expertise in managing these patients, both from surgical, medical and radiation oncology, but also from diagnostic interventional radiology, gastroenterology, both from a point of view of interventional GI, because endoscopic ultrasound is very important, particularly in pancreatic cancer, and also in hepatology and transplant hepatology in particular. We at least have one pathologist who's at every conference. Nancy Brumfield, where is Nancy? I saw her there. Hey, man. Hey, Nancy, as our nutritionist, has been extremely helpful in dealing with the malnutrition issues that are very common in these patients. And we have clinical trials, and we'll hear later from Jessa Blount, who's our genetics counselor. And so it's a great group, and I think that being able to discuss these patients at frequently and on at such a broad level has been tremendous in terms of speeding up decision making and hopefully making a difference in the survival of these patients. As you might imagine, there's not a huge amount of data supporting the use of these multidisciplinary groups in the care of patients. I think it's definitely been championed by leaders in breast cancer care and also in colorectal cancer. But in terms of HPB, there's not a whole lot of data, but there's a small series of patients, small series of papers that have been published over the last 10 years, which do show that there are some benefits when retrospective review is performed. And a lot of this is from pancreatic cancer data, but if you look at the Hopkins data from Tim Paulick's group, they found that discussion and presentation of patients at a multidisciplinary level resulted in a change in clinical stage in 20%, change management in a quarter of situations, and importantly, decreased time from biopsy to treatment quite significantly, and also to completion of all pre-treatment consultations. And I think that's particularly important for tumors of the pancreas and liver, where patients will often need to see not only surgical oncology, but medical oncology, and then interventional radiology, and potentially also radiation oncology. So it's a lot of people to see, and the quicker we can decide which of those people a patient needs to see and when and how, then the quicker patients can actually get on with their treatment. I think it's very interesting and also very intuitive that if you make decisions as a group, you're more likely to combine treatments rather than operate in silos. And so I think over the last year, just in our experience, discussing these patients at a multidisciplinary level has not only helped us manage these patients, but helped bring forth new data from recent trials. And I think a great example of that now is our discussion regarding the use of radioembolization in combination with chemotherapy for patients with metastatic colorectal cancer, standardization of staging, and also development of specific protocols. And I think a great example of that is our protocol for liver biopsy now for patients who have primary liver cancer, where we not only biopsy the tumor, but it's a standard protocol that at the same time a biopsy of the non-tumor normal appearing liver is performed so that we get an idea about the patient's underlying liver disease. And so in my review of the literature, there's like one particular paper that looks at the role of multidisciplinary groups specifically for primary liver cancer, HCC, and that's from the group out at UT Southwestern in Dallas, in which they compared outcomes before and after initiation of an HCC-specific tumor board, and they found that patients generally appeared to present earlier, and also that, for the HPB groups, there's a shorter time from diagnosis to treatment, and this is a huge difference, a decrease in 3 months, and also that there appeared to be some sort of survival improvement. And so how have we done over the last year? So this is for calendar year 2016, purely at the Mitchell Cancer Institute, and you can see that primary liver cancer and pancreatic cancer or periampullary cancers really dominate the tumor board, with smaller contributions from secondary liver cancers and also from biliary cancers and neuroendocrine tumors of the pancreas. So I think that it's been a pretty busy year, and I think that it's been a very helpful forum for discussion of these very complicated patients. And as you might expect, when you look at the breakdown for how we've taken care of these patients, it's very much like the initial algorithm I described, where the transplant or resectable patients are often one group, and liver-directed therapy is about a quarter of what we do. There's a small section of patients who get chemotherapy, mostly sorafenib, and that there's a significant minority of patients who unfortunately have untreatable disease. And I'll wind up there, but I'm not sure how I'm doing for time, but maybe we'll save questions for the panel session at the end. Thank you very much.